for the participants.
So TNOA ஒரு பேப்பர் மாதிரி ஒன்று போடுவோம் சார். The how COVID has changed orthopedic practice in both in தமிழ்நாடு அப்படின்னு ஒரு ஏதாவது ஒன்று போடலாமா?
நீங்க லீட் எடுத்துக்கோங்க, will help. என்ன we are too much in hand. நீங்க எடுங்க, we will help. இது
நீங்க ஒன்னு அனுப்பியிருந்தீங்க அன்னைக்கு ஒயாசிஸ் கான்ல இருந்து they are doing ஒயாசிஸ்ல இருந்து they were doing a study போல இருக்குல்ல on hip replacements.
நீங்க லீட் எடுத்து ஒரு பிஜி கொடுத்துட்டு
ஒரு சின்ன ஒரு क्वेश्चनर மாதிரி பண்ணிக்கலாம்ல சார்? something we can TNOA ஜர்னல்ல பப்ளிஷ் பண்ணிடலாம்.
கேஸ் நீங்க எல்லாம் எழுதி கொடுங்க, we will just do it up, we will follow it up.
சரிங்க சார், we will plan something.
நீங்க என்ன பேசுறீங்க சதீஷ்? நீங்க என்ன ரீப்ளேஸ்மென்ட்ல பேசுறீங்களா?
ஆமா சார், டோட்டல் நீ ரீப்ளேஸ்மென்ட்.
நான் இந்த தடவை எல்லாத்துக்கும் ஆல் குட் சப்ஜெக்ட் கொடுத்து வேரியஸ் முதல்ல ட்ராமா முடிச்சுட்டு அது பேர் கோல்ட் ஆர்த்தோபெடிக்ஸ்.
எஸ் சார், எஸ்.
அண்ட் இவர் எங்க ஹாஸ்பிட்டல் இவர் வராரு, பீடியாட்ரிக் ஆர்த்தோபெடிக்ஸ்.
வெங்கட்தாஸ்.
வெங்கட்தாஸ். அனில் ஜெயின் ஆன் டிபி tuberculosis. அனில் ஜெயின்.
வெங்கட்தாஸ்க்கு 2 போட்டிருந்தீங்க. பர்தீஸ்.
ஆமா, எக்ஸாம் பாயிண்ட் ஆஃப் வியூ தானே.
ஓகே சார்.
எக்ஸாம் பாயிண்ட் ஆஃப் வியூ ஹவ் டு தி ஸ்டேஜிங் எல்லாம் சொல்றேன். அதே மாதிரி சிங்காரவடி வேலைக்கும்
சரி. எக்ஸாம் பாயிண்ட் ஆஃப் வியூ, எக்ஸாம் பாயிண்ட் எனக்கு ஓப்பன் இன்ஜுரியில என்ன எக்ஸாம் பாயிண்ட் ஆஃப் வியூ?
இல்ல இது வந்து மெயின்லி ஃப்ரம் த பிராக்டிஸ் பாயிண்ட் ஆஃப் வியூ ஆல்சோ. ஏன்னா அவங்களுக்கு எக்ஸ்போஷர் டு இந்த மாதிரி சப்ஜெக்ட்ல ரொம்ப கிடையாது. இல்ல இந்த டிசிஷன் மேக்கிங் and implant, how long to give the antibiotics, the debridement is very important, which many people don't do that.
Yes sir.
So அந்த மாதிரிலாம் ஒரு basic things தான் மெயின். ஏன்னா the basic things are not understood. நான் அன்னைக்கு ஒரு இது அனுப்பினேன் இல்லையா, அந்த ankle fracturesல.
ஆமா சார், கரெக்ட் சார்.
நிறைய இப்போ எல்லாமே இந்த debridement is not done very well. Only intuitions maybe where is done by the plastic surgeon and the orthopedic surgeon. மற்றதுல எல்லாம் சும்மா அப்படியே தையல், ஈவன் இந்த ஒரு ஃபிளாப் மாதிரி இருந்தா கூட அப்படி தையல் போட்டு விடுறாங்க. the whole thing comes to the first after 1 week later to us. அந்த மாதிரிலாம் நிறைய என்ன வருது. people have no concept about that. எக்ஸல் ஃபிக்சேட்டர் போடுறான், என்னமோ போடுறான், டெப்ரைமெண்ட் பண்ண மாட்டேங்கிறான், அலைன்மெண்ட்லாம் ஒன்றும் கிடையாது.
இன்னும் அதெல்லாம் கொஞ்சம் கொஞ்சமா. பட் ஓவரால் அர்லி டேஸ்க்கும் இப்போ ஓரளவு பரவாயில்ல இல்லைங்க சார்? இட் இஸ் பர்குலேட்டட் டு எவரிவேர் நோ சார்.
அப்படிங்கிறீங்களா?
டோன்ட் யூ ஃபீல் சோ சார்? ஆர்
இல்லை, காம்ப்ளிகேட்டட். மெயின்லி மோஸ்ட் ஆஃப் த காம்ப்ளிகேஷன்ஸ் ஆர் மெயின்லி பை ஹைட்ரோஜெனிக். தட்ஸ் வாட்
இப்போ முதல்ல இருந்த விட இப்போ ஹை வெலாசிட்டி இன்ஜுரிஸ் அதிகமாயிடுச்சுங்க சார்.
ஆமா, ரொம்ப அதிகமாயிடுச்சு. நாங்க what we are teaching in the before 2000,
yes sir,
ரொம்ப difference. And also one has to be updated regarding the interlocking and all that. அதெல்லாம் ரொம்ப ரொம்ப கஷ்டம்.
Yes. பாலிட்ராமா தான் இப்போ அதிகமா பாக்குறோம் சார். நாங்க எல்லாம் இந்த இண்டிவிஜுவல் போன்ஸ் எல்லாம் ரொம்ப கம்மி ஆயிடுச்சு.
ஆனா இப்ப குறைஞ்சிருக்குமே உங்களுக்கு இல்லையா? ரொம்ப இருக்கா இன்னும்?
இல்ல, இப்போ இந்த லாக்டவுன் டைம்ல we got more. ஜெனரலி பாலிட்ராமா அந்த மாதிரி அதிகமாயிடுச்சு.
ஆனா இப்ப டாஸ்மாக் ஓபன் பண்றேன் எல்லா இடங்கள்லயும். So that again will come back again. That's a feeling, this one for us.
Yes.
We've had so many spine injuries, sir. எல்லாம் மரத்துல இருந்து விழுந்து.
ஆமா, எல்லாம் மரத்துல இருந்து விழுந்துட்டாங்க. கரெக்ட். எல்லாமே வீட்ல இருந்துட்டு வீட்ல இருக்க மரம் ஏறி பார்க்கலான்ட்டு ஏறி விழுந்திருக்காங்க. We also had increased number of fall from trees.
சார் இதுல எங்களுக்கு என்னன்னா சால் இந்த பனைமரத்துல கல்ல இறக்குற இதுதான் நிறைய போயிருக்காங்க. டாஸ்மாக் இல்லாதனால.
ஆமாமா. டைம் லிமிட் இருக்கா சார்?
இல்ல you can go up to 40 minutes 1 hour. Then you can question answer chat box போட்டுட்டு. சரிங்க. And I think Jaykumar is the moderator today. Is it Jaykumar today?
Jaykumar போட்டு. Yes.
Yeah. Yes, sir. He will be giving the questions and you have to answer. Take your own time.
Okay.
See that the boys they hammered into their brain.
It's coming in theory கேக்குறாங்க சார். All open fracture classification and mangled extremity எல்லாமே injury severity எல்லாமே தனித்தனியாவும் கேக்குறாங்க, கம்பைன்டாவும் கேக்குறாங்க. Trauma classification systems.
இல்ல பாலிட்ராமா கூட நீங்க ஒரு தடவை போடணும்னு நினைக்கிறேன். நம்ம actually அந்த TN trauma கான்ல பாலிட்ராமா செஷன் was there, no? It was nice.
ஆமாங்க சார். Yes sir. Probably if everything goes on well, we'll do it again this year, sir. Otherwise, we'll do it virtual at least.
Yeah. Mostly வந்துடும் face to face வந்துடும். People are itching to come for face to face.
Voices நடக்குமா என்ன தெரியலையே.
அது இன்னும் சொல்லலைங்க சார், பட் நடக்கும் போல எல்லாம் பேசுறாங்க சார்.
இப்ப எல்லாம் ஹைபிரிட் தான் வரும்ன்ற மாதிரி தான் இப்ப எல்லாரும் பேசிட்டு இருக்காங்க.
ஏவோல we are planning hybrid. Case discussions and lectures will be online, and then satellite centers which we want to do workshops.
Another 2 minutes we'll start, sir. Just check my. Jaykumar, start பண்ணிருங்க.
Okay, sir. We'll start. Good evening, everyone. Welcome to the 8th session of Professor AD's virtual clinics for postgraduates. And today, the topic is decision making in open fractures by Dr. J. Deenadayalan, sir. Sir needs no introduction. He is a well-known faculty in India as well as abroad. Sir was the past president of Tamil Nadu Orthopedic Association. He is the senior consultant at Ganga Hospital and heads the trauma division in the Ganga Hospital. Currently, he is the AO Trauma India chairperson of the educational wing. I welcome sir, and we are very happy to have you in this session of our virtual clinics. I request sir to proceed with this talk, and 2 points regarding today's session. Initially, there will be a half-an-hour session lecture by sir, followed by a polling session. There will be few questions for the attendees, and the attendees have to vote regarding the option or the answers for the questions. After the polling session gets over, then we'll go on with the case discussion following it. Okay. Over to you.
So is that fine, sir? We'll do like that.
Yeah,
sir?
Yeah, that's fine. Thank you. It is my pleasure to be associated again. So, sir, thank you, sir. Thank you, Satish. And this is a very good continuation of what was done in the first version. And as Professor said, we will keep it to the basics of open injuries. I'm not going to show a lot of cases, but I just want to get your principles in order as far as open injuries are concerned. So the mainly what I would be interested in is to make you understand about this open injury and also when to do amputation or salvage. And then we also need to know different classifications. We have to know that the debridement is the key in open injury management for a successful outcome. And also we need to have a fixation outcomes based on the wound characteristics, fracture pattern, and bone loss. I'm sure all postgraduates would know that open fractures are the ones where the fracture communicates to the external environment. By far, why are we worried about an open fracture? Open fracture, by far, we are worried because sometimes there is a problem with bone union. Infection becomes prevalent problems and also functional restoration. We have gone beyond an era where mortality was very high. That was era of life preservation. Now we have come to an era where functional restoration is important. So these are the three important factors that determine the outcome of your open fracture. You have to have bone union without infection and a good function. So let us look at why we are worried about these parameters. We know that for a fracture healing to take place, the fractures undergo all the stages of healing, like stage of hematoma, granulation tissue, callus formation, modeling, and remodeling. But unfortunately, what happens in open fracture is the fracture hematoma is washed out. Because of the wound, the entire fracture hematoma comes off. So there are no source for signaling molecules. There is no cellular cascade that gets initiated out of the hematoma. And also the platelets that are key factors in producing the factor, that is a prostaglandin derived factor, or transforming growth factor beta, the factors that are released by the platelets, which are responsible for chemotaxis and angiogenesis, it doesn't happen. So that is why we are worried about an open injury. And also if you look at it, suppose if you are having an open fracture, imagine the soft tissue that is damaged. Because of the soft tissue that is getting damaged, blood supply to the bone also gets reduced. So anything that you want to do for these fractures, you have to make sure there is no further disruption of soft tissue. So soft tissue handling becomes important, and whatever the soft tissue that is attached to the bone must be preserved. So this is the key concept in these open fractures. And also if you take, for you that if it has to go on to the next stage, like that is the angiogenesis, and then the formation of osteoid and all, we need to have a closed environment. That is very important. Only when you get the closed environment. Suppose if it is open, you have to provide a flap or a cover, and then it brings in some more blood supply. And once it is covered, then there is a formation of neovascularization. And later on, at this stage, because if you have given an adequate stability, then there is a metaplasia that takes place to formation of chondrocytes, and then osteocytes are formed, and then it becomes bone. So actually what you are looking at in open fracture is the stages gets delayed because of the devoid of cover as well as the loss of hematoma. That is why you have to provide early soft tissue cover and also stable fixation in these open fractures. If you could give, then the cells would be there to get proliferated, and then the stability also will give the fractures to go on to heal. Next area that you are looking at is, because there is an open fracture, when the patient falls, Moment there is an impact on the ground, what happens is the bone comes out, and then when it goes in, it sucks a lot of material, that is whatever the dust material is there outside on the road, it takes it in. That is why this is called the suction effect. Moment the bone comes out and goes in, it takes a lot of mud particles inside. But it's also true that whatever that is contaminated on the road may not be the organism that is causing the trouble. But when it comes to hospital, the bugs that are growing in the hospital seems to be the ones that are causing infection. So you have to be very careful, because when there is a contaminants, if you are able to debride it completely, like excise, and you give it like a clean surgical wound, then it becomes like a surgical wound. So there is no way contaminants would be there. So the key factor is to remove all the contaminants that has happened at the time of accident. The key is also how quickly you do it. Suppose if these contaminants become incorporated and get colonized and then start replicating, suppose if the critical levels reach 10 to the power of 5 organisms per gram of tissue, then the risk of infection becomes high. That is what is important. So when the patient comes in, you debride it well, or suppose when the patient is there and then if you keep doing multiple dressings, suppose if somebody sees, then again somebody else have to see, and then it goes on like this, then the hospital environment contamination becomes more. So all this put together, you have to be very careful that moment there is an injury like this with so much of mud particles, you have to, all these open injuries must be treated urgently for one reason, that the contaminants, you must not allow them to multiply to a level to which the infections will happen. And also it depends on the virulence of the organism and local and general factors of defense like local vascularity, cover, unstable fixation. Suppose if it is a part of a polytrauma, then again you see the systemic effects of polytrauma will also take over, and then it will delay all your treatment. So you have to be careful, and then you have to plan accordingly. So that's how it's very important that open injury management is made quick and all the parameters that are required for it to be done swiftly. And this trauma, whatever the tissue damage that has happened along with the foreign debris and the bacteria that is proliferating, if you are able to do everything right, then what happens is the early antibiotics, administration of surgical debridement and stabilization of associated fractures with early coverage of closure, you will succeed in these. In a situation where you are also having the other effects of the trauma like leaky capillaries and then the edema, all those things to settle down, the other advance that has happened is the negative pressure, which pulls off fluid that is, and then it decompresses the interstitium, which helps in healing of the tissues. So these are the ways by which an open fracture has to be managed. But open fractures by far is a spectrum. See, like you can have a small wound over the fracture site, or a wound that can be away from the fracture site, but still there can be communication to it. And then you can see increasingly violent or ways by which you can get. Suppose if the high violence injuries are there, it can be a part of a polytrauma. So when it is a part of a polytrauma, then you need to look at all those life-threatening injuries, and also see the polytrauma is a disease of hemorrhage. You need to look at all the parameters that are associated with hemorrhage, and then you have to manage them well. The first and foremost criteria that you apply when it is the severe open injury is whether it can be amputated or salvaged. So we have to look at whether these can be get into a good functional restoration can be achieved in these patients. So when the patient comes, you must show urgency. You must follow ATLS protocol. And then the hemorrhage, I said, it is the disease of hemorrhage. The resuscitation is the key in achieving this. Suppose if you delay resuscitation, again, that also can cause infection. So you'll have to understand, because when you delay the gut flora becomes, it can come into bloodstream and then it can cause infection. So assess the complexity of the wound quickly. Antibiotics and tetanus toxoid must be administered quickly. And then all of them, you must think it is in terms of a damage control scenario. There can be a damage control type of resuscitation. There can be damage control in skeletal stabilization. So after that, once you do all these, then you have to make a reconstruction plan. Moment the patient comes in, you all know about the triage, the START triage, that is simple treatment and rapid treatment. So simple triage and rapid treatment. So this START triage, if you do, once an open injury comes, you must mark it as red. Red means urgent or the emergency treatment. You know that triage, I don't want to go in detail about it, but it is simple, like you need to look at the respiration and then your circulation and then the mental status. Based on these three, you decide about what type of triaging that you are going to do. All open injuries must be triaged as red and then immediately shifted for management in the operation theater. So when you are dealing with the moment the patient comes in, so ATLS protocol must be applied, get the airway sorted out. Once the airway is sorted out, the hemorrhage control, limb-threatening conditions like compartment syndrome or vascular injuries must be sorted out. Always document, because the memory is very short. People's memory is very short. So what happens is, suppose if you go on to the treatment, suddenly they will say that if something goes right, it is all right. Whereas if something is not all right in between your treatment, they would not remember the initial wound. So they will ask various explanations as to why this has happened, why that has happened. So documenting, especially the photographing of the wound, is very important. So you take the photograph, retain one with you and give it one photograph to the patient. You must follow that religiously. Sterile dressing, once only you must apply. Limb splintage, because moment there is a wound, you have to keep all the limb in right position. It helps in pain relief, and also whatever the kinked vessels will become all right. You can examine for the vascular flow, everything can be right. So next is your antibiotics, tetanus toxoid and analgesics and radiographs. All the associated injuries like head injury, pneumothorax or abdominal injuries, like you do a fast scan and then get it sorted out, pelvic injuries. These are the one which have got direct factors, that is directly dependent factors for mortality and morbidity. So this must be sorted out quickly. So when you do the ATLS evaluation, you will sort it out. And also circulation. So make sure that the hemodynamic instability is sorted out. Now, you will ask me what is the right fluid that is being given. So this is the first question that you will have to answer as far as an examination is concerned. So you must know that ringer lactate is the choice. The solution of choice would be ringer lactate. Yes, you can also use isotonic saline, but if you are asked what is the single most crystalloid you will use, then you must say ringer lactate. What is the amount? That is 1 liter. You must immediately give 1 liter. Earlier we used to say 2 liter. Now the modified ATLS protocol says 1 liter. And then the blood products, that is 1:1:1. That is packed cells, fresh frozen plasma and platelets. This is the thing you have to remember. And then any of these situations comes, if it is a part of a polytrauma, then you need to know the lethal triad. So once you know that, then you will be knowing about these situations and then you will sort it out. As I already said, it is the documentation that is the key. As a postgraduates, if you develop the skill of documenting from the beginning, take it from me that you will become very good. Documentation not only in injuries, documentation in theater, everything you write it in detail. When you write it in detail, like for example, when the injury comes in, you must also ask what happened before. How was he? What was the pre-injury status? And then as the injury happened, you must ask how many passengers were with him. And if the associated passengers were dead, that means it was a very high velocity injury. So all these will give a clue. And also most importantly, you must note the comorbid factors. The comorbid factors also will play in the treatment aspects. So as you examine this injury per se, like when you locally examine it, you must have a proper exposure. All the deformed limbs must be splintered well. You must get it straight. Moment you get it straight, number one, pain also will reduce. Kinked vessels will become straighter and the blood flow will become better. Venous return will be better. If there is an arterial injury, you will also assess well. If there is a vascular problem, you will also be able to feel or not, you will be able to understand. So this is the time you have to do that. And then once you do it, if there is a pulse is doubtful, then you have to make sure that you can check by pulse oximetry or a hand Doppler. You can use a hand Doppler to make sure that there is no vascular injury. And also it is the same time you have to get the neurological examination also done. And then it is very important. So neurovascular examination. So usually we say, don't fall for the obvious. What is obvious is the wound. Wound moment, everybody will jump in and look for the wound. When it is bleeding, you must give a compression dressing. Take a photograph and give a compression dressing and then go on to examine remaining all of them. So you must go on to the ATLS protocol and do everything thoroughly and then get going with this. Suppose if the pressure is not sufficient, if you are giving a compression dressing and if the pressure is not sufficient, then you can also apply a tourniquet. But mind you, you can apply a tourniquet, but inflating the tourniquet is important. The moment you inflate, somebody must be continuously monitoring the time. Suppose if you inflate the tourniquet and forget it, then your limb is completely lost. So application of tourniquet is the last protocol. You must not use it in the beginning. If it is bleeding a lot, then you want to complete, then it must be done near the theater. That is near the theater. That means when the anesthesia is being given, you can inflate so that you know that your time is ticking from then onwards. So make sure that tourniquet is inflated only when you start the surgery, not before, because if you are applying a tourniquet and send them for x-rays and all, then you are losing the limb. So you have to be very careful. So this is the last thing you have to do. But do not panic. Suppose if it is bleeding, do not panic. Don't keep on putting artery after artery, then you will crash all the other structures nearby. So this is one of the old picture we had in our this thing. So we just make sure that you don't panic in the area where you are in, because you want to catch hold of the vessel. Just compression dressing is sufficient. Neurological examination, you must make sure that it is done. So you have to do a touch and pinprick testing and then also look for the compartment syndrome. At this stage, you institute an antibiotics. Antibiotics, mind you, a lot of people would say it is prophylactic. Somebody might say therapeutic. So it is because, but whatever it is, in our mind, it is almost always it is therapeutic, because you know that your contamination is there. You know that hospital environment, it is going to cause infection. So you have to start it off. Whatever the hospital infection, that is the hospital organisms that are there, you start have an antibiotics that will act against it. And it has to be started as early as possible. So it has been said that if it is started within 3 hours after the injury, then it is good enough, it can control your infection. Suppose if it is organic or sewage contamination, add metronidazole. And tetanus toxoid in all farmyard injuries. Tetanus toxoid becomes almost like a protocol. You give it to every patient, but farmyard injuries, because of the anaerobic infections, you have to definitely give it. And also, like gas gangrene was in early days, it was thought to be of very significant. The anti-gas gangrene serum was also given early days, but nowadays we are not giving as a routine. So only tetanus toxoid is being given. The choice of antibiotic is dictated by what is the hospital contamination. And also there is no need for any prolonged antibiotic treatment. So what we follow is cephalosporins, that is until first debridement, and then till the cover, that is within 72 hours, you can continue it for caproxine. Gentamicin is added if there is more contamination. Metronidazole in all farmyard injuries. And clindamycin if there is anaphylaxis to penicillin, if in case you want to start it in some of the cases where you feel that anaerobic infections are high. So these are the guidelines that we follow. And then immediately you have to take trauma series, AP and lateral view of the injured one, and then joint above and joint below must be included. These are all the post-graduation points. You must always remember that any X-ray you take, joint above and joint below must be taken. And also, moment you look at it, look for any gas shadow or foreign particles that are there because it's an open injury. And then these are the three you must take: pelvis, chest, and spine. Because like any polytrauma, open injury being a high velocity injury, you must take all these. So you will have to make sure that there is no pelvic injury, chest injuries are ruled out, and then spine. And then when they come into the theater, you must do the FAST, that is the focused assessment sonography in trauma. So once you do that, then in a situation might come where you may have to do a CT scan. When there is a complex trauma is there, you may have to do a CT scan. And also whole body CT may be required in a situation where it's a component of a polytrauma. So this is how you evaluate the open injuries. Once you evaluate it, next is your question of when moment you take them to the theater, then first thing that you have to take it is the debridement. This is the key to success. So what exactly you do? Debridement is an active surgical procedure. It's not like just putting a warm water or thorough water. Early days, they used to say, so the solution to pollution is dilution. But that sentence became very famous. But you see, what is important is not just pouring water, but what is important is actually surgical removal of all the foreign particles. Remove all the dead and avascular tissue and foreign material. Wound washing is not debridement. You can do the wound washing only at the end of your debridement. Leave only viable vascular tissue without any contaminants. You must leave only viable tissues. Determination of viable tissue is the single most important factor when you do the debridement. These are the three key points you must remember. So here you can see like there are two ways you can do. Number one is you must use tourniquet. Always use a tourniquet. Anytime you use a tourniquet, you see better because the moment you cut some tissue, it won't bleed. As it bleeds, what you do, you mop. Once you mop, again, a contaminant will come there. So it is difficult. So you always use a tourniquet and then debride it. And under magnification, if you do it, is very good. So that's why if you are trained to do with magnification, it is good. Or otherwise, you must have plastic surgeons as your colleagues, then you can do the debride. But as an orthopedic postgraduate students, you must remember that you have to do under tourniquet and magnification. If you can buy, it's a good one. And then also like there was early rule saying that you have to do within 6 hours and things like that. But there are a lot of articles which has come, you can do as early as possible. And there are also articles which has said that you do it when it is convenient for you, when every personnel is there, when theater equipments are good, all those things are good. But take it from me, like whenever you have an open fracture, if you allow them to stay somewhere, stagnate somewhere, your mind also won't be peaceful. You have to get it going quickly. If you get it going quickly only, then you are doing a good treatment. That's why in the beginning itself, I said, organisms multiply in the wound. So you should prevent it. That is the treatment. So there is no rationale as that. So immediate, it is not like 6 hours you can wait, 12 hours you cannot like that. It is immediate management you must do. Debridement must be immediate. That is no doubt about it. And also like the irrigation. So as I said, the early days they used to say you pour a lot of water and then you just dilute it. It should be all right. Not like that. There is also one article which says for grade 3B gustilo injuries, up to 12 liters of irrigation fluid you can use. There are some articles which said that some solutions, antibiotic solutions, all those things can be, but it has been proven beyond doubt that there is no use of all those things. So wound irrigation is done only at the end of debridement, that is by surgical debridement. Now you see, this is one of the video that I have made when I did webcast in Switzerland. So this is there in the AVO archives also. You can see when you do the debridement, it is the margin of the skin must be excised. Only you should not immediately connect the two wounds that are there. So first take out the margin, and then once you take out only 1 millimeter at the trim, only at this you must remove, because If you take it off completely, then you need a flap immediately. So that is why you have to, and then undermine the edges. Whatever that is loose tissue is there, you have to undermine it. Moment you undermine it, then you know that there are two wounds. Intervening skin bridge will be degloved. So because of the degloving, you have to connect it. Once you connect it, then you will know that underneath it, there will be some amount of frayed tissues. And those, you can see that is the frayed tissues which are undermined edges. So you can take it off. And then once you know that, you have to identify where is the fracture end. So you can extend the wound. So you have to extend the wound. Always you make a atypical incisions to extend the wound. And once you extend the wound, you see the tip of the bone. Tip of the bone is the one that is impacted to the ground. So you have to curate all the tip of the bone. Then you see in the plane, within the plane, you can see there are a lot of bones that are there. So all those bones that are without devoid of soft tissue, it easily comes off. Those which are attached, this is called the tug test. Once you do the tug test, then it will be known that it won't come off. The muscles, you see, you're pinching it. If it is staying in the same position, that means it is, if it is not bouncing back, it's a problem. So you know that the muscles can be seen, like you know what are the muscles that are good or bad. It is by 4 C's, that is color. You know that you have seen a lot of forearms being operated in tourniquet. You see how the muscles are appearing. So it will appear little pale. Suppose if it is any darker brownish muscles are there, that means they are all necrotic muscles. You have to remove it off. You pinch that muscle, and if it stays in same position as it was seen in this video, if it stays in the same position, that means it is not bouncing back to its normal tugger, then it means that that is a dead muscle. So you'll have to remove it. So that is called the Dovey consistency. Then if it is, when you touch with the forceps, so when you touch with the forceps, if it is, so when you touch with forceps, it will contract. If it is not contracting, then again you will have to remove it. And when you cut it, it must bleed. Suppose if it is bleeding, then it's a good muscle. So this is the way you identify the way muscle. Because why you have to be very concentrating on the muscle is because they form a very good nidus for your bacteria to colonize and then multiply. So you'll have to be very careful. You have to remove whatever the muscles that are necrotic. You have to leave only the viable tissue. At the end of it, once you are done, you have to curate the end of the bones also. And then suppose sometimes intramedullary contamination would be there. You will have to remove all those by curating. And at the end of it, you do a irrigation. So after that, you do an irrigation and reduce the fracture. If you reduce the fracture, that is the best stability you can give, not by the implant. If your fractures are, if the serrations are completely interdigitating with each other, that means they are you got the length all right, you got the rotation all right, you got the alignment all right. So that is why when you see the bone ends and then get it reduced correctly, then your debridement is very well done. You have reduced it, then you have to go on to fix the bone. And of course, soft tissue management comes. If there is no skin loss, then you can suture it. If there is skin loss, then you will have to think only about debridement, which we will come to you. We will come to that later. So this YouTube is available. You can also go. That is a very short one that we have made, but in the YouTube there is if you type my name, it will come. You must type Dina Dayalan Jayarama Raju. It will come as the video will come. So now once you debride it, that is the stage you start classifying it and also scoring the wounds. Classification, you all know that it is the Gustilo classification. Gustilo classification is the language of communication for any orthopedic surgeon. So having said that, but it also has got a lot of like inter-observer error rate and all those things put together, then there is a problem associated with that. So on the contrary, because of that 3A and 3B injuries, we have published is the score. The score is, what we do is, the score is also one of the questions that comes in. It has to be red. It's also in the Rockwood green also it is there. So it also come in Campbell. So questions also come in DNB exams. So it is mandatory that you also know about the Ganga Hospital score. So it is based on the simple principle that any injury that has happened to the leg, it involves all this. That is, skin is involved, then your bone is involved, and then the functional tissue like muscles and the nerves are involved, and then the patient is associated with it. So it can be a part of any of these, and then there can be a problem because of the injury itself, or a polytrauma scenario. Any systemic problem can also impact on the outcome of the open injury. So you have to take a personal, that is why it's called fracture personality. Everything has to be taken together. So the scoring is given like 1 and 2 means there is no special skills are needed for treatment. 3 means little bit of special skills are required to get a good outcome. 4 and 5 means they are severe injuries which will demand more skills, many procedures, and also compromise the results. You might also need some others help also. So all these put together, we have framed it according to it's an incremental score, and this is the wounds that is seen. And also, like if you take it into this wounds without skin loss, that means they are primarily closable wounds. If it is away from the fracture site, it is simpler. If it is at the fracture site, you have to decide. If it is skin loss is associated, even if it is away from the fracture site or at the fracture, it's more problem. So anything above 3 and onwards, you have to think of only a flap procedures. Again, here the bone also is the same thing. It is an incremental score depending upon the fracture that is involved. So it is like a transverse, comminution, joint, segmental fracture, bone loss less than 4 centimeter and more than 4 centimeters. Similarly, the partial injury of muscle or complete or repairable injury to muscle, irreparable injury to muscle, where there is a posterior nerve also, posterior tibial nerve also can be involved, loss of one compartment and more than one. Like that, it's incrementally more injuries. So it is sequentially incremental injuries that are grouped as that. And also like there are comorbidities that are added to that. You have to add 2 points to each of the comorbidities. Suppose if some open injury comes very late, or sewage contamination, or age more than 65 years, fat embolism or coagulopathy, all those things like that you have to take into account. And then these are various parameters that are there. And then we have found out that it is not that you can give a very fixed point for that. Depending upon the infrastructure, skill, cost provider, culture, and then patient factors, lot of things has to be taken into account. Based on that, we have given the gray areas like 15 and 16. Depending upon those factors, you can think of either salvage or amputation. Whereas up to 14, we have found that you can salvage it. 17 and above, it requires amputation. That's what in our study we have found it out and we have published it. And you can see this comes as 15, but patient had a myocardial infarction. That's why you have to go and amputate. Whereas the Ganga Hospital score not only gives you that basic thing to decide, but also tells you about the reconstruction pathways. Earlier, we were doing only like resuscitation to skeletal stabilization as stage, and then soft tissue cover was done later. But now you can also do total reconstruction depending upon the score. Suppose if you are these things, fix and close, fix and skin graft, fix and reconstruct and close, all of them can be done in a group where the group score is less than, total score is less than 9. Whereas you have to wait, fix and wait and all those things, or a staged reconstruction you will have to do only when score is 10 and above. So take this example. So you get a score of, this is a fracture, you get the total score as 4. And because your total score is 4, you can do all the requirements quickly. And then like you can do primary closure, you can do nailing and then get it sorted out. It's like a primary management of any closed fracture. But you see the skin wound is more. Skin wound appears very big, but still the total score becomes only 4. When it is total score is 4, again you do the same thing and then they end up with a very good result. And here you see it is not a vertical wound, it is slightly horizontal wound. And again, you see the total score is 5, but the bone, you see bone compared to what it was, the bone score increases when the bone score increases, you see sometimes if it is devoid of soft tissue, you remove it. Then you can also do all these primarily. You can just go ahead, bone graft it, and then nail it, and then come out successfully. And then that also can be managed. So that means the total score is less, then you do everything. Here you can see that though the wound is very big, total score is 7. But what we are doing is, we are doing a very immediate flap. That means immediately after debridement, you are doing a flap. And then again, you are doing everything together, nailing, and then you get a good score. So anything that is less than 9, when you get it, you can do an immediate, that is a global reconstruction. On the contrary, if it increases, so if you keep going above like this, then you have to think only of staging it. So you have to stage it, do multiple staged procedures, and then get the results done. So that is a good way of looking at it. So all your open injuries, you will get a very good outcome based on this Ganga Hospital score. Professor Devada's team also did a study, and they found out that it is overall, it is a very good as far as the decision making and prognosticating the outcome. The success of open injury management is, you have to answer salvage and amputation. You have to tell when to do reconstruction, when not to do reconstruction, what is the number of reconstruction that you do. All these put together, this score has become very good score. And also it tells you about the complications involved in this injury. And overall, in a nutshell, a skin score of more than 3 always requires a flap. Bone score of 4 and 5 require complex reconstruction like transport or free vascularized fibula. Score of 9 or less, you can do a global reconstruction. 10 and above, you have to do a staged reconstruction. Once you decide about the management, that is after debridement, the next is to take a culture. Because we know that the infection is mainly from the hospital. So at the end of the debridement, cultures only are good. Moment the patient comes in, if you take a culture, it is of no value. Only at the end of the debridement, you take the culture. And then next question is, how much to go on day 1? So, but as I said, score is one of the aspects that you can decide. But you will have to ask the general condition. You must know what is the general condition of the patient. Suppose the score is less, if it is a part of a polytrauma, don't be too aggressive. And then anesthesia guidance is extremely important, because anesthetist is the right person to tell you how much to go on that same day. So it's also important that suppose if somebody has got a head injury as a part of a polytrauma along with open injury, you all know that head injury patients require good oxygenation. So anesthesia is the time that you get a good oxygenation. So whatever that is required for an open injury, you do it off at that stage, because when you want to come back next, it will take very long time. So all these you have to factor into it and then do the treatment on day 1. So the personality of the fracture is very important. So you have to take as all of them put together. Next comes the skeletal stabilization. It is the wound and the fracture pattern. All those things put together. Generally, external fixators are very safe to practice. And whatever the ways, like if it is a contaminated wound, if it is an infected wound, if it's extensive soft tissue damage, then you do that. Whereas plate, extremely good in upper limbs. You can do all the plate fixation upper limb. Distal femur, that is wherever muscle cover is good, you can think of a plate fixation. And then, as I said, in a straightforward tibia or a situation where there is a femur fracture in the shaft tibias, shaft femurs, then you can also think of nailing as an option, but provided your score is less than 9. So these are the instances where you can also do a nailing. So there is one of the aspects that you need to remember. Already I told you in the score. So there is also concept about conversion of external fixator to nail. Only thing is, if there should not be any infected pins to go on to do that. If you do that, this is a good way. So once you get the skeletal fixation done, a lot of flaps are available, but generally you have a good discussion with plastic surgeons and they will let you know what is the right plastic procedure for the patient. So essentially what you are looking at is you have to make sure the limb is immediately joints are mobile, and then the patient must be made all right. So like you have to counsel them very well. You have to keep the family, everybody together in this, because a lot of operations you may have to do if there is anything uneventful ending that is happening. So you'll have to be very careful. Counseling has to be done. Let us take this as a final case. So you can see the bilateral injury initially treated and then referred because it was like a polytrauma scenario was also there. And then when he comes over, we debrided it and then we got it straight. And then immediately on debridement, we put the LRS and then slowly we transported it. And then once it is transported, then he gets back. See, like throughout this, you have to be counseling them very well. When you counsel them and then keep the family together, motivate the patient well, then only all this can happen. So even the mobility, joint function, everything has to be kept in place, and then you get the carry on, then they get back to normal activities. So beware of any pre-existing medical illness, and then always keep the family members together in discussions. It is important that the patient's pre-injury level function is noted, and treatment should be tailored to patient's functional needs. In summary, emergency care and appropriate initial management is the key. As a whole, for the success depends on the debridement, appropriate diagnosis with scoring, and then the correct staging. Of course, rehabilitation is essential. Thank you. So after this, you can run the questionnaire. So some of these you can discuss, and then did I take too much of time? 45 minutes. Jay Kumar, sir.
Okay. Can we pose the question now, sir?
Yes, we'll start with the questions, the polling session.
Okay. Just an information to all the delegates. Once the question is posted, on the bottom you will find an icon called polls. Click onto that. It will pop up, and you have to click onto the answer which you are choosing.
So to all the participants, you will be seeing a pop-up on your screen. Please choose your option. We are given 4 options for each of the questions. If you slide down, you have 5 questions. You can poll. You can start your polling.
So the question is open for 1 minute, is it? Is that right, Shashank?
Yes, sir. We can keep it for about 2 to 3 minutes because
no, 1 minute should be fine because we have four questions, right?
No, it will be all together, sir.
Oh, okay, okay.
How many are there, Satish?
People are watching on Zoom and another 65 are watching on YouTube, sir.
Oh. All are simple questions only, I think.
There are some questions also, sir. At the end of the case discussion, we can take them, sir.
Right.
Shall we take it before the case discussion, sir, or after case discussion?
Anytime,
You want to do it?
Whatever you want.
We will close the polling in about 20 seconds, sir. So you can see the results there, sir, on your screen.
Yeah.
DD, sir, you want to evaluate the results?
No, first question, 79% is already are answered correctly.
Yes, sir.
So this is antibiotic wise, lot of variation is there, but cephalosporin, that is the correct answer. 49% anyway answered it correctly. And red, correct, 77%, yes. No, external fixator is the right answer, so 42%. So nearly, so everybody is on the right platform now. So I think everybody has nearly got it right.
Very good.
So
Jaikmar, you want to ask the questions now?
Questions, if you want, we can go.
Yes, sir. We'll proceed with the questions, sir. Few questions are there. The first one is it advisable to do primary bone grafting at the time of SSG or flap cover after debriding?
No, yes, see, for example, see, lot of dead space management itself is a big issue in open injuries. So one of the area by which you can manage a dead space means like when you are debriding it, say for example in a distal femur, or even for example tibia that I showed, when you are removing bone or when you remove muscle tissue, there is going to be a lot of dead space left there. At that space, those spaces, if you are able to close it, when the skin is, there is no skin loss, but you are able to close it without any problem, then you can do a primary bone grafting. But in any case, if you are not able to close the skin or you are not able to give immediate flap cover, then there is no role for any bone grafting primarily. The first and foremost thing is either you can be able to close the skin or you must be able to give a flap on the same day of the debridement. If these two are met, then you can go ahead to do a bone grafting. On the contrary, if you are not able to do that, then the dead space management becomes like you will have to do either a vacuum, that is a vacuum suction, or you will have to put bone cement. Those type of managements you will have to go ahead. So when you ask bone graft, that is the two main things that you have to take into account.
Okay, sir. And that is clear, sir. The next question, sir. After how many days of temporary fixation should we do a definitive fixation?
No, a temporary fixation that you would have done will be based on either it was a polytrauma scenario or it was like a extensive soft tissue damage would have been there or a contamination would have been more. So it is based on what was your observation for your temporary stabilization. So if it was like, there are instances where your temporary stabilization that you have used itself can go on to make your fractures to heal. So there is nothing like you have to change all the external fixators. First, please note that not that all external fixators you have to change it to internal fixation. That decision comes only at the time, like as and when the bone has healed, as and when the soft tissue has healed well, then you think there is a stability of your fracture is in question with the external fixator, then you go ahead and do a internal fixation. So when you want to exchange it, the pin tract there should not be any pin tract infection. Even then, you remove the external fixator and leave it quiet for 2 weeks. Give a slab and then leave it for 2 weeks. That is called the window period. After that, you can go ahead and do a nailing, or if there is a scenario where you want to do a plating, you can go ahead and do a plating. So that is what is important to note.
Okay, sir. The next question is, sir, how do we debride the endosteal side of the bone?
Endosteal side, I told you, like you have to open the fracture side. From there, you have to curate it, scoop it out. So it is the scooping. So use a curette and then see through the end on and then nicely curate it from the ends. So you can also take your curette further down and then curate. But don't poke it inside. From the superficial to deep, you must keep cleaning. So.
Okay, sir. Is there any use of dye in delineating the dead tissue while debriding, sir?
Dye, there is one, even in our hospital, like for the burns and all, when they are doing, they just check with one of the area, but I don't use any dye for that. I don't use anything, but I'm not well versed with that also, so I can't answer that question anyway.
Okay, sir. Okay, sir. Point taken, sir. Another question is, in pelvic fracture, do you use suprastabular pinning or ASI pinning, sir?
In pelvic fractures, we use both. So sometimes we use suprastabular, and then in few cases, we also used anti-superior iliac spine, anti-inferior iliac spine actually. So we use those, but generally, routine as a quick procedure, it is suprastabular pin.
Okay, sir. The next question is it advisable to do wound irrigation in the emergency department itself, or should it be done only in the OT?
I told you, wound irrigation concept, if you keep in your mind, see, a lot of times, I didn't speak about jet lavage and all. See, like when they started using those irrigations, so in the bargaining, in the thinking that you have irrigated well, you tend not to take the cases very urgently. So you might say that, okay, we have irrigated it, let us keep it for some time, and then the theater, if you want to post the patient to the theater, the time will be delayed. So the best is, think that surgical debridement is the one that you have to do. Irrigation comes next after your surgical debridement. Then you will get all the patients correctly done. Otherwise, you will delay your surgical debridement. So you must not think that, okay, in the casualty, we will do irrigation and then take it to the theater and then do the debridement. Not like, sometimes when you irrigate it, when you are pouring water, you might also push some of the contaminants into the deeper compartment. You don't know. So.
Okay, sir. And one more question, sir. In a case of prolonged surgery, say for instance, more than 3 hours, should we repeat the dosage of antibiotics, prophylactic antibiotics?
That is a routine practice anywhere. Like if it is a prolonged surgery, you will always do repeat the antibiotic. But if you are asking about open injury scenario, any open injury that you are doing, your surgical time should not exceed like that, because open injury itself, you have to be very fast. You have to be quickly X-fix it and then debridement and then X-fix. It must be over by 1.5 hours. At the max, you can reach 2 hours, but not not beyond that. So because anything that you are going to delay, if you are continuing to operate beyond that 2 hours, 1.5 hours, I think it is more like a polytrauma. Whatever that happens, complications arising out of polytrauma will do happen in this. So you have to be very quick. So don't be interested to take these cases beyond 1.5 to 2 hours.
Okay, sir. Okay.
If you want to ask me, the 3 hours antibiotics, is it a routine practice? Yes, it is a routine practice to give another dose of antibiotic.
Okay, sir. Points clear, sir. The next question, sir. Should the free bone, irrespective of the size of the bone, should we remove all the free lying bone fragments, even if it's a very big fragment?
100%, you must remove all the bones without any soft tissue attachment, except those which are contributing to the joint. Suppose if it is contributing to the joint, which is a key fragment for movement of the joint, you should never remove it. You can nicely debride it, because whatever the portion that is forming the joint, it is a part of your metaphysis, and they all act like a osteoarticular allografts. So they will retain some amount of, they will survive somehow. And whereas if it is a diaphyseal segments, which is a bone that is devoid of soft tissue, you must definitely remove it off.
Okay, sir. Points well taken, sir. One more question, sir. In a case of segmental closed fracture with soft tissue injury and skin discoloration, can we do a unreamed nailing on day 1?
Segmental fractures are something you have to be careful, because segmental fractures by far in open fracture scenario is known for necrosis. So they will become infected. So that is why safer practice in segmental fractures is external fixate. Suppose if you are 100% certain that contamination was less, there is no degloving of the skin, then you can think of doing a nailing.
Okay, sir. I think there are a few more questions, sir. Shall we proceed to the case discussion and then take the rest of the questions, sir?
Yeah, okay. So this is a 27-year-old male. So you can see that there is a comminuted fracture. Wound is also you are able to see, but initially we are doing an external fixator. The reason for doing it is, you know that there is a situation where you can see there is an abrasion here. Whenever you see an abrasion like this next to a wound like that, sometimes there can be a degloving of the skin underneath. So for that you have to observe. Suppose if you want to observe it, then you need to give some time. So that is why initially external fixation has been done. And you can see what we are doing is we have taken the muscle that is there around it, and then we are covering it there just as a protection for, it's a biological cover. Suppose if you leave the bone exposed, it can get desiccated, and then it can, when it is exposed, it can die. So you can use these type of methods. You can use there is also collagen sheets are available. They're all okay, but if you are able to get surrounding muscle and cover it, it is a good way of doing a biological cover. Once it is done, then you see next is the skin graft that has been done, and then that area becomes better. So it is actually muscle flap with a skin cover, skin grafting. But you see, we have retained the external fixate. We have not changed the external fixate. If you want to see the frame characteristics, you must know that one pin is closer to the fracture site, and then the pin expand to the bone. So you know that that is the way you have to apply the frame. And then once you do that, over a period of time, you see, we have not exchanged it for a nailing. It is easy to exchange it for nailing, but as long as you know that these fractures as the time passes by, is going to heal well, then you can keep it and then go on to make them walk. So this is one of the ways you need to look at it. Not every fracture you need to convert them into nail. Not every fracture you have to think of plating. So if your external fixator characteristics are good, if it is giving adequate stability, you have to go on to maintain it. One of the concept is, you see this is a diaphyseal fracture. You can see there is a lot of, that is combination is there. You need a relative stability. External fixator is one of the mode that gives relative stability. And when you are following the principles of length, alignment, and axis, it will go on to heal well without any problem. So you have to apply the principles every time. So you must not think today is X fix, tomorrow is interlock nail, not like that. If you applied all the principles well, there will never be any problem. See, now this patient has healed, that is united, no infection, you can see the function. So all of them are restored. So that is why never jump into a situation where you have to think all of them needs conversion. So this explains one of your questions you have asked me before. So let us go on to the next patient. So like this is a 21-year-old male. See, like this injury looks very innocuous, isn't it? So you can see there is a wound here. There is a wound, abrasions like this, and these are all like contused skin. And you look underneath what has happened. So there is a extensive comminution all the way from proximal to distal. See the amount of swelling that this patient has come with. And you see, the moment you look at it, you will think that, okay, it is innocuous, and then you just think of something, doing something for this patient, you will end up with problem. So having said that, what happens now? Whenever you have all this type of comminution, you must take it that the skin is degloved there. And that's what happens now. Initially, we have put external fixator. You can see between these two skin now, initially debrided, then debrided, and then you can see slowly it undergoes necrosis. And then as it undergoes necrosis in 1 week, then we will have to debride everything. Suppose you take this scenario, when you debride it, what happens? When the skin is removed, it is on the medial side, isn't it? So all the bones are going to be exposed. So this is what is happening. So when it is getting exposed like this, you'll have to think of early flap cover. So we did an early flap cover. We wanted to get an early closed environment. We got it done. But however, you see this ends up with some infection. So the infection is not that because of what the flap has been done early and all those things, but it's purely because from the day 1 to the necrosis, 1 week of time, it has given a sufficient time for whatever the muscles underneath, which was ischemic, which was necrosed, has inoculated the bacterium, and then it has grown. The bacteria has got colonized and then grown, multiplied, and resulted in infection. So now when this happens, because there is such a nasty fracture, and then flap also failed now, like it is all infected now, question comes as to whether you need to amputate or not. So, but you get into a scenario where patients are not giving consent for amputation. So you have to manage it. And then you see, like we had to go ahead and do a redebridement, and we applied WAC and then sorted it out. And it at 4 months time, you see, you get this type of fracture. So you have some of the fragments are there here, and then that, so it is all attached like that. And then whatever the bone gap you see, they are all loose fragments that has come off. These are the fragments which are having some amount of soft tissue attachment. Because it has got soft tissue attachment, we have retained it. But fortunately, you see, it is some sort of attachment is there somewhere. And then it is a 25 centimeter bone defect. And then you can see all this, you can think, could you nail it? You can put proximal and distal nail and leave all these fragments in between and just think of bone graft. or you can also think of removing entire thing and do a bone transport. Also, you think of vascularized fibula, but problems persist because there is infection was there, and then very short distal and proximal fragments. Sometimes your transport, you may not be able to do it. So all those are the, it's unpredictable results also. So amputation, sometimes you have to still think about it. But what we did was just like a traditional locking method. Earlier in days, what we used to do is like pin and plaster. Why I brought this case is because as a postgraduate students, you must remember this pin and plaster technique. That is why I got this case for you. So we applied the pin and plaster technique. That means pins will be outside. Along with that, we incorporate the plaster, and then this becomes like a locking. The plaster will lock the pins, and then you allow them to walk. As they walk, then slowly you see some amount of bone is forming. It is at 10 months. And then we just maintained him with caliper. So continued the same treatment. At the end of it is at 20 months. You can see it has united. And then he has gone on to walk, and then limb is saved. These are exceptions. It can never happen in all the cases. But this is a method you must remember. When you are at a receiving end of saying that the limb has to be salvaged, patient not giving you the consent, but with all the problems that you have to manage, you still have to think of some sort of methods to go on to make it heal. So remember the pin and plaster technique. That also will work for you, and then functional bracing for some time. It will go on to help the patients to heal. So first case was about using external fixator till the end. Second one is about noting that not all of them need all your fancy nailing or plating. It is still your traditional methods can still help the patient to heal. Only thing is you have to be cautious throughout. Don't be too adventurous in doing the treatment. So next case is a 20-year-old. You can see that he has got a femur fracture and the tibia. Again, you see, this is a common scenario sometimes you will get. Sometimes you will get massive injury, soft tissue injury, but a small fracture. But you see skin wounds are less, but underneath there is a big comminution. Whenever you see such two wounds, always take it that underneath it's a degloved skin. So this is one point I wanted to bring it. So in all the cases I showed, it is to make you understand that this concept must be very well understood. And then now you see we have given this case scenario, and then if you go, then we connect both the wounds and then debride it very well. And then again you use an external fixator, and then you see like here it is. Now, as I said in the first case, this is also a lot of comminution is there. Your pins are correctly positioned well. And then if it is stable enough, it should go on to heal well because it is going to be a relative stability pattern. And then it is, Ganga Hospital score is 11. So you have to do a staged reconstruction only. So right now you wait and then see once the wound cover is done, and then you wait for it. You can see that as the femur is also healing, you see some amount of callus in this also. And then though there is some, because at certain stage we removed the external fixator, and then it was showing some deformity here. But however, it went on to heal with mild deformity. So this is the final result he gets. But you see, patients, not all the patients will complain about deformity. You just have to coax them well, and then as they walk, continue to, mild amount of deformity, still patients will be able to accept it. But there is something called acceptable alignment and non-acceptable alignment. Suppose if it is medial angulation is more than 10 degrees, you have to definitely treat it. But if the patient complains of pain, anyway, he will come back for you to treat it. So now, right now, it has healed well, and functionally he is all right, no pain, and he has done well. So the take-home point is that external fixator can be used as a primary and definitive treatment in open fractures. Circumferential bone contact and a good clinico-radiological alignment. That is, as I said, in all the cases that we have managed, all of them had a circumferential contact. And then there was a good length alignment and axis was maintained, so it went on to heal well. So, is there time?
Yes, sir. Yes, sir.
We can go on, sir, please.
You can go on, sir.
Okay. So this is a type 3B injury that I got it here for you. And he has got other fractures as well, like femur and proximal ulna, which were managed at different patterns. So this is one of the questions you people ask. So it's a segmental fracture. So what happens is, see, again, similarly, you see like there is a wound here. There is a wound. I didn't want to bring all the ghastly wounds and then show you. I can show all of them a lot. I can show different technique like Kapana technique and all those things, but they are not necessary for you to understand. This is a simple thing that I want you to understand in today's lecture. So whenever you have a wound here and a wound there, you must take it is a almost always there can be some degloving. So this is a segmental fracture. Any comminution, any segmental fracture is some sort of high violence bone injuries, and all of them are known for non-unions even in a closed fracture. So you have to treat them with excessive caution when it is having a soft tissue injury. So you can see that moment there is a degloving is seen and then opened out. You can see that entire bone is devoid of any of the soft tissues. See, that is what happens in tibia. And then suppose if you think, if you don't notice the degloving and then you just debride here and debride there and just do a nailing, and in 1 week or 10 days later, imagine this undergoes necrosis. Already you have nailed. So that means because of the wound, the extra periosteal blood supply is lost. And because you ream it, endosteal blood supply is also lost. Then you end up with a lot of additional problems. So now what we did is, you can see that we covered it. And then once we covered it, and as we remove the external fixator, we know that we have seen that there is a middle segment is devoid of soft tissue. And we can see that this breaking down. This is breaking down because the middle segment was devoid of soft tissue. It will undergo necrosis, and then it is going to become infected bone. So that is why we remove that bone. As we debride it again, we remove that bone, do the cross leg flap for the bone that was exposed, and then that is the removal. And then you do the corticotomy, transport, and then once it is transported well, and then it goes on to heal. This is around 20 months it takes, 22 months, then so nearly 2 years. This is the 3rd year, and then you can see it finally heals well. So any segmental fracture, you must be extremely cautious. You must not be too aggressive in nailing, because segmental fractures also can end up with having a less blood supply by open injuries. So you have to be very careful on this. So assessment of bone during debridement is a key step. Bone transport is a gold standard method to manage long bone defects. But most importantly, any of the transport that you do, you must make sure that equinus is prevented and all the joint contracture should never happen. That is the key. So you have to be continuously monitoring it. Physio must be given, patient must be explained. Once you tell the patient, they generally follow it, and then it will be okay with it. So any other questions I will take, because these are the main points I wanted to bring today. I didn't want to show any other major injuries. So
thank you very much, sir.
Wonderful expression of the whole of the open fractures, which I really wanted to say that we have brought out all the points for the postgraduates as well as for the practicing orthopedic surgeons as well regarding decision making, which it was very apt for this moment. And I'm very happy you were able to participate in our program. I'm really thankful to you again. And
thank you, sir. It is our pleasure to be there, sir.
Much benefited. You can give us feedback later on.
Okay, sir. Okay, thank you, sir.
Satish?
Thank you so much, Professor Didi. It was an excellent talk as usual. But I think you reached out to the postgraduates by giving the basics necessity for them, as well as not to go in for very heroic things and make sure your X-fix is done properly. Your decision making is right from the beginning. Those are points, I think, amazing, which every young orthopod should be thinking about. And you have brought it out very clearly, sir. Thank you so much for being part of this program, sir.
Thank you, Satish. Thank you, sir. Thank you. It is a pleasure to be with you, sir, for the meeting. Thank you, sir.
Thank you, Denan.
Thank you, sir.
Thank you very much, sir.
Jakeman, what about next Tuesday?
Next month.
Yes, sir. Next Tuesday, we have a session by Professor Govardhan, sir. He'll be discussing about non-union of fractures. So I invite all attendees and all the postgraduates to come in large numbers and get benefited by our professor. He's the regular examiner. He was the examiner and he's still the examiner for DNB as well as MS Ortho. So kindly make use of this opportunity. Thank you very much.
Thank you.